Okay, I am recording right now.
Okay.
Daniil, your turn.
So my name is Daniil, and we are going to look into a very interesting study named "Are You at Peace? One item to probe spiritual concerns at the end of life." It is an article by Karen Steinhauser and alumni, and it is a cross-sectional survey study. Perhaps you may not be very familiar to survey study. It is because it is not very widespread in the clinical medicine, but it is very interesting, but with some specific concerns, as I will mention earlier. You can see that it is published in Archives of the Internal Medicine and a journal with a rather high impact factor of 9.6 as of 2006. Here I want to discuss a problem, some kind of introduction. At first, maybe I can ask you a question. I know that usually you should ask me a question, but I want to ask you a question. What is the goal of medicine? The goal of medicine, in your opinion?
So, you mean in general medicine?
Yes, any medicine, like general medicine and all the specialties. What the main goal?
Good question. Does anyone have idea to answer? I think there is no actually right or wrong answer. So I think it's relief. Give patient relief.
Yep, it is a very good answer because usually clinicians are taught about some model and about a lot of information about cure and prolonging life expectancy. So in the university, we learn how to cure patients, how to prolong their life. But another important goal of medicine is to relieve stress, to relieve suffering. So especially when we can't prolong patients' life, especially in terminally ill patients that suffer, medicine is obliged to ease their suffering. And there are several domains of suffering. There are physical suffering like pain, dyspnea, fatigue, etc. There are emotional suffering, social suffering, and also spiritual suffering. So what is spiritual distress? It is when patient asks questions like, why me? What is the meaning of my disease? And why, what will be after the death? And if there will be something, and what is the meaning of my life, and etc. And it is really common in terminally ill patients. And it is an important cause of suffering, and to relieve this stress, and first to recognize and then to relieve, is an important goal for palliative care. So there are some practical points that spiritual distress might influence treatment decision and adherence to treatment. I think it seems rather obvious because like when you are in spiritual distress and you don't want to, you see no meaning in living, you may not be adhering to treatment. And there are also a practical point that usually clinicians work in the time-limited setting, and appropriate assessment of spiritual issues is out of their capabilities. And there is a question how spiritual distress can be assessed in a quick, appropriate, reproducible, and efficient way. And one of the main idea here is quick, because usually clinicians don't have a lot of time to speak about, with patients about their spiritual issues. As we said, spiritual distress is an important issue in the end of life. Being at peace, concept of being at peace was reported by patients family members, and healthcare providers to be an important constituent of a good death. And 89, most of the patients and most of the family members agrees with the importance of coming to peace with God. But spiritual issues like being at peace not always about religion, because some people are agnostics, are not very religious, or atheists. So being at peace is rather more general thing. And peacefulness is strongly associated with emotional and spiritual well-being, as suggested by some studies. So this is a survey study. In survey study, participants asked to fill some blanks with questions and to answer on them. Surveys that rely on participant self-reports, so they are susceptible to some biases that are specific to survey studies, like social desirability biases. It means that patient may be more susceptible towards answers. It may give those answers that are socially desirable, or for example some answers that physician waits from the person to give. And survey studies, responses in the survey studies greatly depend on the verbal construct. How do we formulate a question? It also depends on the situational pressure. For example, when a patients are alone and she has enough time to fill in all blanks and etc., it may be not very pressurable, and it's okay for him to have some time to think, etc. But for example, when he have a lot of relatives or physicians in the room and he asks some questions, he may feel situational pressure and give socially desirable answers. Like you can see on this picture. So the authors of the study tried to develop an item that will be one question that will correlate with the overall spiritual state of the patient. Some studies suggest that coming to peace with God considered important at the end of life. At peace with God, at peace with personal relationships, at peace with myself, they all correlate with each other, and it is not significantly different whether you're at peace with God or whether you're at peace with yourself. So it's pretty the same thing as research suggests. And to promote inclusiveness, the final item employed wording just "are you in peace?" So what is to be in peace? Farlek's Dictionary of Idioms says that to be in peace is to feel an overall sense of contentment or acceptance of a situation. Not to be in conflict with the situation, for example, with God, with your relatives, etc. And it's also interesting how it could be translated in Russian. And it is really difficult. It was really difficult question for me, and I think it can't be translated ideally. But there are some variants, like чувствуете ли вы смирение? Находитесь ли вы в мире с собой, с окружающим миром, с Богом или с близкими? Спокойно ли у вас на душе? Есть ли у вас мир в душе? То есть, допустим, утверждение «у меня мир в душе», и пациент оценивает, он согласен с тем, что у него мир в душе, или не согласен. Это что-то вот вроде этого.
Actually, may I just ask our audience what they, because it's very difficult concept, especially when you're trying to translate idioms like to Russian. And it's usually, I really like your fourth translation, like спокойно ли у вас в душе. I think this is really can be used in clinical settings. What other things? What people like most in? So I just want you, like everyone, just take a second and write on chat like the number of translation which you like more. Just take some seconds on this. I just interesting. Like, what do you think? Okay, Екатерина also like fourth. Спокойно ли у вас в душе? I think this is also probably can be difficult for those who don't really think about having soul, because soul is also kind of concept of not everyone believe in this. But I think like for Russian population, especially like given the fact that most of us have like we are like Orthodox mainly, like yeah,
especially elder population and
yeah, exactly, yeah, that's what I think. Yeah. Первый и второй имеют слишком религиозный оттенок. Ну да, если про Бога, да, то да. Вот про смирение действительно, вот мне сразу, да, смирение это первое, как бы key feature of Orthodox religion. Найди смирение. Окей. Спасибо. Все могут продолжать, да, написать, можете написать. Мне просто правда интересно, как. Окей. Sorry for interruption.
Okay, so we may continue. Okay. So peacefulness, being at peace, is correlated with some qualitative measures, qualitative items in another qualitative study. For example, to feel peacefulness, to be in peace, is correlated with having a chance to say goodbye, having someone with whom to share their deepest thoughts, making a positive difference in the lives of others, giving to others in time, gifts or wisdom, and having a sense of meaning in their lives. So there was a study about end-of-life care, and patients and relatives of the deceased patients and clinicians were asked about a good death and what is important in the end of life. And those who said that peacefulness is important, they also said that other things are important also. So what was the study objective? Authors wanted to explore the concept of being at peace using quantitative data collected from patients with advanced life-limiting illness, to examine correlations with other assessment of spirituality and quality of life, to identify constructs associated with the experience of being in peace. So they tried to assess how many patients are being at peace using some scale, and they tried to they tried to assess what the correlation about being at peace and other quality of life measures. They reached from two hospitals that are not very far from each other in the Durham, and there was no comparison group, but it's maybe seems obvious. How can we compare? Inclusion, there was inclusion criteria. Criteria is patients with advanced serious illness that were stage 4 cancer or congestive heart failure with ejection fraction of 20% or less, or COPD with very little forced expiratory volume, or dialysis dependent and stage renal disease. So patients that have overall very poor prognosis. And there was one exclusion criteria. It's a patient with a severe cognitive deficit, as measured by short portable mental health status questionnaire.
One question. You said that it's obvious that there are no comparison group, and usually, like, if you don't have comparison group, it's very hard to make any conclusion, because like, it's probably you find something like universal thing, or you find something which only related to the sample which you're interested in. And I think I just interested in, like, what is it really okay that they don't have comparison group? Do you have any idea, like, for whom the questions about spirituality can be also important? Like, if we don't talk about patients with terminal illnesses, like, what condition can be also important when we talk about spirituality? For example, I, as an addiction psychiatrist, I'm of course thinking, like, first thing which come to my mind is substance use disorder, because, for example, in Russia there are a lot of rehabilitation centers which are based on religious, and it's kind of like religious based organizations which have like rehabilitation programs, and it's one of the first like thing which, when you go to a meeting, anonymous alcoholics or narcomanos, you actually supposed to accept the first kind of rule that it's something bigger than you, and it usually is reference to the God, to God. So I actually think that probably those who are looking for, like, who looking for rehabilitation or like substance use disorder, it can be also interesting to ask them about spirituality and how they answer. Like, I just think there are some options to compare. I think, like, everything can be compared. Like, you just need to find out the main like have some logic when you when you choose what is your comparison group can be. Maybe someone have any idea, like, what comparison group can be used for, like, checking the spirituality of patients, and in which condition it can be important. So if you have any idea, you can, like, share it with us, or, like, type it on chat. So I think, like, chat is also good strategy to use to share your thoughts. Okay, if no one, so yeah, let's continue.
Maybe there should be a comparison group that, for example, would absolutely be in peace, like, I don't know, the chaplains, the religious stuff, and but I don't really know. We can compare, for example, with a person with substance use disorder, and it would add some maybe some add to generability, difficult word, of the conclusions, something we imply. It is also interesting to search. So there were 320 patients that were reached, that were asked to participate. 53 patients refused to participate, and 90 demonstrated significant cognitive impairment. So 248 patients completed the interview. There were used three questionnaires, three surveys. First is QoL-E, a 31-item assessment of the quality of life at the end of life. The second was FACE-IT-SP, and the third was APIS. So QoL-E has 4 domains about life completion, in which in every domain there are several questions about life completion. 1, relationship with healthcare provider. 2, symptom impact and preparation for the end of life. Each question have an answer on a 5-point Likert scale. So 1 point means you disagree completely, and 5-point means you completely agree. QoL-E is a validated and reliable tool. It had 2-step validation. It validated on terminally ill patient. So it's rather good to use QoL-E in this setting. And one item in QoL-E asks patient about the extent to which are they at peace. So here we have an example of this questionnaire, and on number 23 we have I feel at peace. So if they can choose not at all or completely or any other response in between. So FACIT SP stands for Functional Assessment of Chronic Illness Therapy Spiritual. It has 5 domains like spiritual, physical, functional, social, and family and emotional well-being. And it wasn't designed specifically for use in the terminally ill patients, but it's rather broadly used, well-validated, and reliable general quality of life assessment tool. But the limitation is that it was not designed and validated in terminally ill patients. And EPs stands for Established Population for Epidemiologic Studies of the Elderly, and it was validated on the elder population. It was not validated for the use in terminally ill patients either. It was used in several prospective studies to study the predictors of mortality, hospitalization, placement in the long-term care facilities. So patients at first completed the survey, and then they were followed up for a long period. It was elder patients, age more than 65, and some of these items in this questionnaire were associated with mortality, hospitalization, etc. As we have age more than 65, it's also a limitation, because as we can see here, no, it would be further. The overall population age is elderly, yes, but there were some patients that are rather young. For example, minimum age was 28. For statistical analysis, were used mainly Spearman correlation test, because the authors compare ordinal variable, like 5-point Likert scale, and ordinal variable like other scales in the other questionnaires. And they also compared response of 5-point Likert scale on the question I feel at peace with some demographics variables like age, ethnicity, sex, marital status, diagnosis, and site of recruitment. It is not very clear why they use Spearman correlation for the categorical variables. Perhaps more suitable would be to use Wilcoxon test for this. So they didn't mention if they used any other tests and why they used Spearman correlation for categorical variables if they made so. Here we can see some sample profile of patients. We can see that mainly patients were black or white. There was a little over representation of men, but not significant. Most of patients had cancer, and age was median of age was 61 and ranged from 88 from 28 to 88. So authors discovered that there was no significant relationships of being at peace with ethnicity, education, sex, diagnosis, site of recruitment, or marital status. So being at peace was not dependent on any of these demographical factors. But there was small but positive correlation between age and feeling at peace. So we can say that that older patients are more likely to feel at peace. And it can be explained that usually patients that are younger, they are struggling for life, they are not ready to die, and they often have they often have more spiritual distress. They want to live more. Then there was correlation of being at peace with other subscales in the questionnaires. For example, being at peace strongly correlated with emotional well-being and spiritual well-being. There was a moderate correlation with functional well-being and social well-being, and correlation with physical well-being. What does it mean to correlate strong, moderate, or weak? There are some like empirical rule of thumb, so to say, that and it varies between the textbooks, between studies. For example, authors say in the other study that they considered weak associations to be when R are from 0.1 to 0.3, moderate from 0.4 to 0.6, and strong more than 0.6. If R is 0, that means there are no correlation. And if R is 1, it means that correlation is absolute. Like it means pretty the same thing. So there were also correlations with peacefulness and two dimensions within facet spirituality subscales, purpose and faith. So to be at peace strongly correlated with overall spiritual state of the person as measured by other questionnaires. So authors draw a conclusion that asking patients about the extent to which they're at peace offers a brief gateway to assessing spiritual concerns. Can this conclusion be made on the given the study results? I want you to maybe speculate on these questions, and could authors draw more accurate conclusion?
Sophia, what do you think? I decided to choose more aggressive tactic and ask by name. So I see Sophia. Sorry, Sophia.
Yeah, hello everyone, I'm here.
Hi.
But, oh, excuse me.
So can you introduce a little bit yourself, like who are you? And
Okay, I'm a third year student, almost fourth, and it's this theme is quite difficult for my mention. I don't know, for my brain, and so maybe I'm today won't be selective. Excuse me, please. And it's very interesting theme, but it's quite strange, and I don't think that this conclusion is very useful. I don't know, just as a lot of elderly people, like elderly wives, says the same without any experiments and without any studies.
And what conclusion would you make if you was a author or co-author?
I can't imagine I'm trying this type of studies, and so it's difficult to say to me what I wanna say.
Okay.
Like conclusion.
So
Sorry.
I want just to maybe repeat and conclude something that the authors wanted to measure if asking, "Are you at peace?" can assess spiritual distress the same as all these questionnaires with a lot of questions. Can you simply ask, "Are you at peace?" and assess patient's spiritual distress as effective as a lot of questions in the specific surveys. So, and they say that yes, asking patients about the extent to which they are at peace, it offers a verificative way to assess their spiritual concerns.
I'm not actually agree.
Thank you for your repeating, but yeah, it became more clear the aim of this study, but I still don't understand for what is it. Just no, it's difficult. I wanna stop in my thoughts.
Yeah. I actually think that this probably one of. Actually, I also think that authors not really clear about their hypothesis and how they prove it, because if you look on conclusion, it looks like their hypothesis that this one item questionnaire can be like gateway to assessing. It's actually they don't. I not really think that they are trying to say that it's reliable measurement for assessing spiritual distress, but they also kind of accurate with their conclusion, and they say that okay, like you can use it as a like gateway for more in-deep conversation with your patient about spirituality and how spirituality can influence on decision-making process about treatment. So I would like to say that authors very accurate with conclusion, and I kind of agree that this is conclusion is not just reflecting results. It's like a little bit like it's for like further direction, like what is actually its need for clinical practice. So I actually agree with their conclusion. It's yeah, I think this is like brief and it can be get away. So Aida Kuliyeva, do you have any ideas like why they made this conclusion, or it can be better conclusion? No? Okay, maybe Pavel? Do you have any ideas?
Yeah, I think that conclusion is quite enough. It's not very strong, but it's very, it's made in a careful way. So we can't argue a lot with it. I think it's appropriate here, and no, all of this article just give us idea to think about spiritual concerns also. I mean, as a for our practice, because we don't think much about these questions when assessing patients, for example, in clinic.
Mm-hmm. Good point.
So it's was useful for me to think about such deep questions that they also matter.
Yeah.
So, I agree with you, but unfortunately, being a nerd, I wanted to make more strict conclusion, but I think that this conclusion is also okay, and it's that in terms that it is that it provides a brief gateway to assess spiritual concerns, and it is very practical and really useful and good conclusion. But if to say about interpretation of results, I think that studies suggest, yes, that being at peace is correlated with spiritual concerns. But if to be more precise, I would say the degree of consent with "I feel at peace" statement is strongly associated with spiritual well-being assessed with multi-item questionnaires. And it provides a brief gateway to assess spiritual concerns also. But we can't say that the study proves that feeling at peace is associated with spiritual well-being overall, and that physician asking a patient if he feel at peace, that it is a good, for example, and sensitive way to assess spiritual concerns. But I think that if to speak more general, and if to speak about implementation, the conclusion, like resume, is okay. So there are some things to discuss about study. The first is the sample representative? Can results and conclusion be extrapolated to general population, maybe to the Russian population, to people of any age, race, culture, religion, etc.? Because terminally ill patients are sometimes not very old. Can we say that if we ask this question to the person who are 25 years old and he's terminally ill, if it would be okay to rely on this study, etc.? So any ideas on this question? And the second, is response given by patient in the setting of a survey is similar to response given by patient to verbal version of the question, "Are you at peace?" Because the authors suggest that you can ask a person if he is at peace in the conversation, and rely on these questions to briefly assess his spiritual distress. And is there a possibility of difference in responses between asking patient this specific question only and verbally, orally, and giving him a pile of service with question of interest among them? So I would like to hear your opinion on this.
Ekaterina, any thoughts on first one? Let's start from first. Is the sample representative, and can the results be what about generalizability of these results to Russian population? Any thoughts? Ekaterina?
Hi everyone. I don't know. Is the sample is these results can be extrapolated for Russian population? To my mind, no, because culture and religion makes sense in this question. So about other questions, probably age can be also significant to this question. And to my mind, this sample is rather small in order to extrapolate these results to general population. And you asked if this result can be extrapolated to population without terminal illness or with terminal illness. If with terminal illness, I suppose rather also no. Without terminal illness, of course, no. Well, that's my thoughts.
How do you think, so you said that age, culture, religious can change the results, like which for example, we conduct the same study in Russian population. So, and for example, in this study, we see that age was positively correlated with being in peace. So, do you think in the Russian population it would be opposite, and like younger population would be like more than in peace in Russia than there in? So, I mean, I totally agree that this kind of question is kind of especially like it's spirituality. It's very I would like to say it's not only like culture, religion. It's very individual, and it's very like there are multiple like component on this concept of spirituality, and everyone understand this phenomena like, individually. And I actually believe that it's also about humanity, like being a human, and to believe in someone which like higher than you, like in higher power, and believe that like we are not like you're not just like meat. You have a soul, you have something like bigger than this. And I think this is very universal, especially when you face on death, like you realize that you like can die tomorrow. So, and I think this is universal for any human, because death is very universal thing. So, of course, like culture, religion, and do you notice that they actually don't say nothing, like they don't talk about different religions. For example, when they describe socioeconomic status and other characteristics, I don't actually notice that they have something about religious. They don't ask the questions about religious. But yeah, am I right or not?
It seems to me, yes, there were nothing about religion.
Yeah, and this is strange also, right? Because it's India.
I would agree with Marina in terms that the question is formulated very well, that it can be understood and interpreted and answered by a person of any race, culture, religion, and age. Maybe there can be some drawbacks in a very specific population, like maybe in a patient with very specific philosophy, like I don't know, that are very different from Western. Like in Russia, we are like all have pretty same philosophy and spiritual beliefs, but maybe in the Eastern population, like in Buddhists or others, maybe it can be difficult to say that it can be extrapolated on that population. But I would say that overall, in the Russian population, it may work. Ideally, it should be proved, but I think why not?
Yeah, and I think we already have good versions for Russian question.
Yes,
No,
so
question in Russian.
we are to conduct a study, I think.
Yeah. Okay, and what about second question, which kind of way, like we have a this discussion about this, but what other people think. So Marina, can you share your thoughts about this, like about second question?
Difficult one.
Yeah.
May I say?
Yeah, sure.
Sure.
I have some thoughts, and so it was maybe my first thought that, as I understood, question "Are you at peace?" in this study, that was a part of some questionnaire. I don't remember what is. If I remember second, and so maybe they had so conclusions that it's almost the same, a lot of questionnaires and just one question, because it was like a preparation. And so when a person answers a lot of questions and they are almost the same, of course, about different parts of their life, but the main aim is this question: Are you at peace? And it is just is looked from different sides, and so it's like like a meditation, I don't know, like a preparation. And so of course it will be the same answer for question and for questionnaires, but when there is a single question, and especially if it will be in the one part of questions, like I don't know, do you have pain, or I don't know, do you have, I don't know, vomiting maybe, and also are you at peace? And it will be maybe more strange, and it won't be so it will be difficult to answer to this question so rapidly and so, I don't know, rightful. And so maybe don't I can choose a word in English, осознанно. It won't be the same, I think, because of it's quite a philosophic question, I think, and the answer will depend from a lot of moments of the life. And even, I don't know, people, this person, he was waiting a lot of time for this conversation, and of course after this he won't be at peace. And maybe because of this it's not very quite good alternative. So
Yeah,
thank you.
Yeah, thank you. I think that you raised one of the other follow-up questions about how a doctor who asks this question, how he or she can be prepared for this conversation. Like we open,
yeah, of course,
we open it, but how to close it and how to leave. Yeah.
It's maybe like about Spike's protocol. Maybe we should prepare patients for this question almost the same, because it will be a very, very good atmosphere and very high compliance with doctor, and maybe then we can say that yeah, this answer it will be pretty good for us, and it will be truthful.
Mm-hmm. I wanted to say that Sophia gave a brilliant response in terms that the setting and the previous questions may influence the subsequent questions in the survey. So when a person conducting a survey, when they interpreting it, etc., they should keep in mind that previous questions may somehow influence the question of interest. So it is very important. I agree.
Yeah, it's totally true. So that's why when you make an assessment, like on a clinical trial, it's very important to not skip the part and to provide the assessment as it like follow, like is it kind of like on your paper. I mean, it's super important. And on previous presentation, Anna talked about like it's very important to have the same like print materials, like the same like visual analog scale, like the same paper. And here it's very important if you want good results to use your same schedule of questions.
So I think the third question, we talked about it a bit. Then a question to discuss: can language barrier be overcome? Can we extrapolate results of the study to non-English speakers? We also talked a bit about this. And I think that there are language barrier, but it should be validated just in other languages. It's like a rule. And the last maybe question, authors imply that question I wrote piece can be utilized as substitute to more detailed spiritual assessment. I think that I may be wrong about it. I would not a substitute, but maybe a screening question for further detailed spiritual assessment. But every screening question should have very high sensitivity. Every screening method and etc. should have very high sensitivity. And how do you think, is it sensitive enough to act like a screening question?
Marina, what do you think? Is it sensitive enough? Okay. Ekaterina, what do you think?
Oh, well, how can we understand that person who answers that he is in peace is not in peace? So if I can't explain. Well, sensitivity is about true, false, and that's kind of something
Positive.
I don't understand how can we find false positive or false negative in this case by comparing answers to these questions and by comparing answers to questions in questionnaires. Probably we can do this and probably then these methods can be sensitive enough. I didn't understand in proper manner, I think.
I see what is the problem, that the authors didn't provide the sensitivity, and it is not very clear, not straightforward how to calculate this sensitivity, because we have not a categorical just yes no variable, but an ordinal variable. So it should be maybe some additional I don't know research to convert ordinal variable to categorical, and to convert all the results of questionnaires to the categorical variable, if they are at peace or not, to calculate true positive, true negative, false negative, etc. rate, and to calculate sensitivity. But overall, we don't have the sensitivity, so I would say that we just can't say that it is sensitive, because we have no idea how it is sensitive. So it may be interesting to know what amount of persons who say that they're at peace, who are not really at peace when they are answering the other questionnaires. But yes, it may be difficult because it is an ordinal variable.
Usually when you, like, the point that we don't really have cutoff. Like, for example,
Yes.
we don't have like this information of, okay, like if you answer like 3 or more, you're at peace. If less, you're not at peace. Unfortunately, or I don't know, fortunately, we don't have this information, because this is kind of, it's probe question, and this is like they not actually propose it as a screening question. It's like it's only like a getaway, just to thinking about, okay, like to continue or not to continue. And actually, this is like part of the conversation. It's not mean that, and this is continue from the patient view, not from, like, usually when we use screening and we get this result, okay, like this patient probably have the disease, let's go to next test.
I see.
And here it's just the getaway for conversation. It's not actually, so you ask this question and you just got more information from your patient and from how he answer you, and this is exactly what you can use for like follow-up conversation when you talk about treatment. Because, for example, the point that if patient think, okay, I will die soon, nothing helped me, I forgot about like my medications, I don't see any point to take it, and this question can give doctor the start point for continue conversation, and to like talk more about, okay, like why you're not in peace, like something like this, like, and like what can be, what's happening in your life right now, and to talk more about this, and to change decision about taking or not medication. And I think that about sensitivity, like you can calculate everything, and probably I think that you also can use the questionnaire which already show high reliability and validated for this specific population, and you just need to see, like, this is like kind of like first the simplest analysis. They just show correlation, but you also can have this to do sensitivity analysis, and it's just like mathematics. It's nothing very like hard to do. You just see, like, you just compare the answers on individual level, not on like correlation. So, and it's possible to do. But
so
it wasn't the question for this article. They just look on correlation.
I just thought, like, in terms of some clinical tests, like I used to think. So it is useful to not to think about this question like a test, but just like really a gateway, something that can help, not like a reliable test, a yes or no question, or something to deep into the patient's problems, to dig deep into.
Yeah. And unfortunately, we don't really have these tools, like, which, like, we have EKG, like, electroencephalography, which, like, we can move deeper. But, like, what questions should a clinician ask to be, like, polite and to be, like, not super rude and to be appropriate? Like, what is appropriate and at the same time comprehensive question, which can give you a lot of information, and it's really hard. So that's why they made this research, and this is it's super. So that's why it's super interesting research, and we also should thinking about like how we can communicate with patient and how we can, like, in the condition where we have limited time. So it can be brief and it can be very, very productive conversation. So, and again, like, I totally agree with the Russian population. It's so difficult to extrapolate, and I actually think that it's unknown area, and probably maybe some of you would be interested in discovering this research question: how to communicate with terminally ill patients and how to help them in more proper manner. So yeah, there are just also, I think that you choose this article, it's very important for us because we see how it's not only like pharmacological questions can be interesting, but also to thinking about like what is the effective way of communicate with patients.
Yes, I recently, when I was going through a course of palliative care, I realized that medicine is not only about clinical tests and interventions. It's also a lot about relationships with patients and their comfort, easing of their not only physical suffering, but also it is important to address their emotional and social and special and spiritual concerns, and especially in persons that have serious illness like substance abuse disorder, of course, like cancer, like I think in every specialty there are some serious conditions that require support, not only some medications and tests.
Yeah, totally. And the other thing that what make this research very interesting, that it's kind of easy to do. Like you don't need you don't need to spend money on medications, or like it's kind of very like less risky business because there's possibly like not adverse effects based on this research. So I think this is, it can be actually a student project, like asking different and trying different questionnaire and to look what can be brief version of questionnaire which we already used. So, but how to use it in clinical practice.
And it is rather inspiring that you can you are able to make a project that can be published in a journal with high impact factor. So it's all depend on you. It's not only about money.
Yeah, exactly. Yeah. So Daniil is actually very interesting in this topic about like communication between providers and patients. So if you have any question, don't hesitate to connect with Daniil, and probably you can create some beautiful project together. I think it's a lot of potential here. It can be your area of expertise, like for research.
That is interesting. So I'm free to open to suggestions, but I don't. I really should learn a lot about it yet.
Yeah.
So there are some limitations that we have already discussed. That there are some population limitations that they were drawn from one region, that the most of patients were black and white, and they were underrepresentation of Asian race and Spanish-speaking population and Russian-speaking population. And some strange things about statistical analysis, but that are not critical, in fact, I think, but that they could be more conclusive, maybe. So to resume, I think that it can be stated that being at peace is positively associated with overall spiritual conditions as by various service, and it could be used as a brief gateway to assess patient's spiritual condition. But wide applicability of the results is, I wouldn't say it couldn't be extrapolated or is disputable, but it requires validation on the different cultures, on non-English speaker. It requires validation of the construct in other languages. So, and as I think we all agree that it is a brilliant study with some little drawbacks, but overall it was very interesting for me to prepare it.
And thank you.
Thank you a lot.
Is anyone have any final thoughts on the paper or on presentation? Because I think it's kind of like, okay, I probably say like this one for every presentation, but I think it's really a unique study, and the questions which we discuss it's super unique, and especially in the fact that it's not objective, like, you know, it's the conversation and especially spirituality. It's very hard to to research and to investigate. So thank you for bringing up this topic. And just small reminder that you receive a survey after this meeting, and we also recording this, so I posted on YouTube. I just